They say like 5 out of 9, but usually they'll give you 8 or 9 of these. And then the question is, what are these symptoms, right? So for major depressive disorder, obviously you have a depressed mood or anhedonia. This is important though, that sometimes, children, they won't really present with depression or depressed moods, and instead they will be more irritable. Now, this irritability can also be present in a lot of other conditions. So whenever a child has infections, they're more likely to be irritable instead of in pain. And additionally, whenever they're not well fed, like if they have a malnutrition problem, they'll also be very irritable, and that happens in children. So these symptoms, right? You can use the mnemonic SIG ECAPS, and all of these symptoms, they just make a full comprehensive picture. Like if you ever think about a depressed person, all of these things will kind of work out. They have sleep disturbances. Usually they sleep very less or for much longer periods, usually for longer than 8 hours. They'll have a decrease in pleasurable activities. So whatever a person found interesting or did in their pastime before, now they would just be not interested in that thing. They'll have a feeling of worthlessness, decrease in energy, decrease in concentration, decrease in appetite. However, appetite changes could be either way. Either you develop a decrease in appetite or you develop an increase in appetite. So either thing could happen. They also have psychomotor retardation or agitation, and then suicide ideation. And when we talk about suicide ideation, we'll also talk about the difference between when a person is at a much higher risk for suicide. So an example here would be, when someone says that they don't feel like living anymore and they want to die, that's low risk compared to someone who already has made a plan. So let's say someone has already made a plan that, oh, on this day I'm gonna overdose on these medications, and these medications are, let's say, in this drawer of my room. So because they already have a plan, they're at a much higher risk for suicide. Now you always want to ask these patients if they have ever had a manic or hypomanic episode with depression, because if they have, then you cannot classify them as having MDD, and instead you will classify them as having bipolar disorder. Additionally, the reason, why we ask about manic or hypomanic episodes is a lot of these antidepressant medications. So yeah, all of these antidepressant medications, if you give them to someone who has bipolar disorder, it will aggravate their manic episodes. So that means the patients will be more manic or hypomanic, depending on which bipolar they have. Finally, we have ETC. This is actually important. ETC, it doesn't really have any side effects. And the idea is that you shock the brain so that the depression goes away. A little archaic, but it works. It has a really good success rate and is usually used for treatment-resistant depression. Now, this actually, I would say, is very important. Any kind of psychiatric problem that a patient develops, usually these would be the answer. Either you put them on CBT or either you give them SSRIs. Could be major depressive disorder, could be generalized anxiety disorder, hopefully not bipolar disorder because then they will develop mania. But any kind of major like psychiatric illnesses, you can in theory put them on SSRIs and it should work. Now next we have MDD with psychotic features. Now this is a person who has major depressive disorder, and then after the major depressive disorder they developed psychiatric conditions. So this would usually include like hallucinations or delusions. Yeah, and then everything else is pretty same. Yeah. However, one difference here, right? This part. This is an important distinguishing factor between major depressive with psychotic features and schizoaffective disorder. In that, uh, even if you look at the name, it's major depressive disorder. So the patient is actually actively depressed and now has psychotic features. Whereas in schizophrenia, you might have separation of the uh, psychotic features and of the depression. Additionally, schizophrenia, it's not only with major depressive disorder, it could be with any kind of mood disorder. Next, we have persistent depressive disorder. Now, this is called dysthymia, and it's basically someone who has a low, uh, think of it as like a milder form of major depressive disorder, but it lasts for very long, usually like 2 years. So it lasts for very long and is a milder form of depression. Now, major depressive with seasonal disorder usually will happen in winters, and the idea is that these patients, they would be very depressed or they'll have depressive symptoms only in the winter period of the year. Now, treatment, you can do the standard therapy, so you can put them on CBT, you can put them on SSRI, but you can also do light therapy. And the way you do light therapy is basically you have a warm light in their room, which they can turn on during sundown. So after sunset, they can turn on the light, and it helps regulate their mood. Because the association which was made is that major depressive disorder with a seasonal pattern is actually dependent on how much sunlight a person receives. Next, we have depression with atypical features. Now, couple of interesting things here. Usually, patients with normal depression, they'll have a decrease in appetite and a decrease in sleep. However, patients with atypical depression will have an increase in sleep, increase in eating. These are two. And then they might also have this thing. Wait. Oh yeah, mood reactivity. Now, mood reactivity is basically someone who becomes happy at like good things for a short period of time. So let's say someone has depression and they recently won the lottery. So now they'll be very happy for like 1 or 2 days, and after that they'll go back to depression. So that's mood reactivity. And then they can also develop a leaden paralysis. That just means that their limbs feel very heavy to move, and that's why they'll be very still. Here, SSRIs are the first line medication. Obviously, you can use SSRIs for the treatment of a lot of psychiatric illnesses, but you can also use MAO inhibitors. Now, MAO inhibitors are really good for atypical depression, but the reason why we don't give MAO inhibitors is because they can cause a tyramine crisis. They can cause hypertension, they can cause tachycardia, and all of those side effects. So that's why we want to prevent people from taking a lot of MAO inhibitors. Now, yeah, peripartum mood depression, mood disorders. You don't really need to remember all of these. There's a couple of things you do need to remember. The time. So if it happens within 2 or 3 days after delivery, it's postpartum blues. Major depressive would be around within 4 weeks of delivery. So after 3 days, but within 4 weeks. And then postpartum psychosis should usually be after 4 weeks. Oh yeah, they don't write this, but after 4 weeks, you'll see postpartum psychosis. And one thing is that in postpartum psychosis, the mom might actively try to kill the baby. Yeah, thoughts of harming the baby herself. This is an important distinguishing factor between major depressive with peripartum onset and postpartum psychosis. This condition might also be called postpartum depression. It doesn't always have to be MDD with peripartum onset. But just remember the time, and I think you should be able to answer all these questions. Yeah. Next, we have ETC. And ETC, electroconvulsive therapy, basically you shock the patient. You put like 1 or 2 electrodes on the brain, and then you give them an electric shock. Usually, this is used to treat patients who have treatment-resistant depression or refractory depression. Yeah, and then there are certain side effects but they're not very bad. So usually patients might develop like some amnesia, but it goes away. It's not forever. Disorientation and headaches, obviously you've shocked someone's brain, so they will have some disorientation and headaches, but nothing long lasting, no long lasting side effects. And this is important. There is no absolute contraindications. Pregnant women can receive ETC, elderly can receive ETC, children not so much, but I believe after the age of 15, if they have a very severe depression and they have psychosis along with the depression, you might be able to do an ETC for them. Yeah. Now, risk. So, all of these are risk factors that can increase the risk for suicide. However, the most important risk factor, at least in the US, is firearms. So much so that if, uh, let's say, a person in the family develops depression and even a hint of suicidal thoughts, you want to ask the parents or their significant other to lock away all the firearms in the house and then also just throw away the key. Like, you do not want anyone who has depression or any suicidal ideations to have access to firearms. Yeah. And then obviously, what do you do for suicide risk? You hospitalize them. Oh, yeah, hospitalization. There are certain medications too which can help reduce the risk of suicide. Two of those are lithium and clonidine. No, not clonidine, clozapam. Wait, clo. Wait, what was the name of the antipsychotic medication? Second generation antipsychotic medication can cause agranulocytosis.
Clonazepam?
Clonaz, clonazepam. Oh, clonazepam. Yeah. So clonazepam and lithium. These are two medications which can actively reduce the risk of suicide. No, you want to be very selective when you give them because you can't give them to depressed people. But if someone with psychosis has suicide ideations, you can give clozapine. Or let's say someone with bipolar disorder has suicidal tendencies, then you can also give them lithium. But you cannot give those medications for depression. Okay, yeah. Next, we have anxiety disorders. And yeah, these are all the anxiety disorders. This is a quick overview of those disorders. So we can skip these. There's nothing really important here except for this word. Patients with anxiety, right, usually have a fear or they worry excessively. Now, if it's fear, we could have panic disorder or phobias. And if you have a worry, you could be generalized anxiety disorder or obsessive compulsive disorder. So for panic disorders usually will present with physical signs. That means these patients will have tachycardia, they'll have a fear of dying. So a fear of dying. Shortness of breath is one. Sometimes they might also have chest pain. Yeah, chest pain. Yeah. So a fear of dying, chest pain, shortness of breath. Looking at these conditions or like these symptoms, right? You might think that the patient is having a myocardial infarction. However, couple of things. Usually, it won't be a singular attack. They would have had previous attacks, and then each episode would only last 10 to 15 minutes. So short acting, not short acting, but short effect, and multiple recurrent episodes, and similar presentation to an MI. Fear of death, chest pain, shortness of breath, palpitations, similar. Yeah. Again, treatment can be CBT or SSRIs. Now, one more thing. In patients with panic disorders, you can give venlafaxine. However, venlafaxine should be monitored when you give them, because venlafaxine can increase norepinephrine, which can, in some cases, be a trigger for panic disorder. Additionally, there are two medications which not for panic disorders, but instead for a specific phobia, social anxiety disorder. You can give two medications which are beta blockers and benzodiazepines as short-term relief. However, these aren't long-term, and for long-term, you always need to do CBT. Now, what are phobias? Phobias are irrational fears towards something, and this is important to know that it's irrational. It could be because of a lot of things. Some people have a phobia of heights, some people have a phobia of spiders, some people have a phobia of open spaces. That's actually agoraphobia. Some people have a phobia of social speaking, like public speaking. Any kind of fear which is irrational is classified as a phobia. For social anxiety disorder, it's as the name says. So patients have a problem with social events. It could be social situations, it could be public speaking, or even being in a place where you have a lot of people, unknown people, such as restrooms or, sorry, restaurants, either one. Now, this is important to know that the medications you can use to treat episodes or like one specific event where someone knows that they're going to have social anxiety. One example would be, let's say a patient needs to give a speech at his best friend's wedding, and for that he needs to take a medication because he cannot normally engage in public speaking. So the medication you can give him is beta blockers or benzodiazepines. Beta blockers is the first line medication. However, you can also give them benzodiazepines. Now, what if the patient has asthma? Which medication do you think you'll give the patient? Beta blockers or benzodiazepines?
Benzos.
Benzos. And why not beta blockers?
So the beta
Beta blocker
blockers,
causing bronchospasm.
yeah.
Yeah, perfect. And then agoraphobia, as we said, it's a fear of open spaces, crowded spaces, and usually the not syndrome, but the presentation for agoraphobia will be someone who does not leave their house and they don't have a problem with speaking to people. Usually, like whenever they want to meet someone, they'll invite them to their own house instead of meeting anywhere public. This is very different from social anxiety disorder, which also has like a fear of places. But this fear is because of the people. And agoraphobia is because of a fear of the open spaces or large spaces. Again, treatment is the same, CBT and SSRIs. Next, we have generalized anxiety disorder. Again, it doesn't really say how many, but you need around. Yeah, so there are 6 symptoms. You would need around 4 or 5 to be classified as having generalized anxiety disorder. But the USMLE will give you all of them, and they're pretty similar to depression, where you have a problem with concentration, you have restlessness, which is different here. You can have irritability, muscle tension, low energy, fatigue, and sleep disturbances. Now, one more difference about generalized anxiety and major depressive disorder is that generalized anxiety needs 6 months to be diagnosable, whereas major depressive needs only 2 weeks. Yeah, 2 weeks for major depressive disorder, and then generalized anxiety needs 6 months. Again, treatment is the same, CBT and SSRIs. Next, we have obsessive compulsive disorder. Now, one thing about obsessive compulsive disorder, right? You don't need both the obsession and the compulsion to be diagnosed as having obsessive compulsive disorder. You could have either one of these. Obsessions, they're these recurrent intrusive thoughts, and compulsions are the actions which the patient takes. So repetitive actions, and this is important that they relieve the distress. Again, for step one, they'll give you both obsession and compulsion, but for step two, they'll mix it up with only obsession or only compulsions. Treatment is the same, CBT and SSRIs. Now, there are two different categories that I mentioned here. You have body dysmorphia disorder and then telatrechomania. So we'll talk about telatrechomania before because it's easier to understand. Basically, people who are very stressed or have a lot of anxiety, not specific to obsessive compulsive disorder, could also be because of generalized anxiety disorder. These patients, they will pluck out their hair, and a lot of times that will leave balding. But a lot of times after plucking out their hair, they might also eat the hair. And if they eat the hair, then that could cause gastric bezoar. So that's just a hair ball which gets stuck in the stomach. But pulling off the hair, breaking hair, and one thing that you'll see in these patients, right, is that when you look at the hair, they'll all be in different length and it will be very patchy. Different length of hair and patchy. That's how you can diagnose telatrechomania. So yeah, it's pulling out hair. Okay, yeah, shafts are of different length. And treatment is still the same. So treatment majority of the time is the same. CBT or SSRIs or both of them together. Next we have body dysmorphia disorder, and in this condition, right, patients would be preoccupied with one specific defect in their body. So preoccupation with one specific defect, and usually it will be a minor defect, that their nose isn't the right length or their fingers aren't the right length, something similar. Now, the treatment, they do say it's CBT, but this is actually one place where they want you to be more specific. And what you do for treatment along with CBT is you show the patients pictures of people who have a similar body composition as the patient, and then you ask them to describe that patient, sorry, that picture or that person, and you make them believe that if that person is normal and that person is very similar to you, then you are also completely all right. That's the idea that we're basing this therapy on. Next, we have trauma and stress related disorders. Now, there's two, and the symptoms here are pretty similar, I would say. There is, oh wait, no, sorry. Yeah, these symptoms are not similar. I was actually thinking about PTSD and acute stress disorder. So PTSD and acute stress disorder, they have the same symptoms. The only difference is the time. Acute stress disorders, acute stress disorder is between 3 days and 1 month, whereas PTSD is more than 1 month. Yeah, more than 1 month. Now, if you have someone who develops these same symptoms, let's say someone develops hyperarousal, avoidance of associated stimuli, reemergence of experiences such as nightmares or flashbacks, and distress within like 1 or 2 days, then that's not exactly acute stress disorder. It's just stress associated with the symptom, not symptom, but the situation that the patient had. So it's normal stress. If it goes on for more than 3 days till a month, then that is acute stress disorder. And then if it goes on for more than a month, that is PTSD, which is post traumatic stress disorder. Treatment still the same. Oh yeah, for acute stress disorder, this is one of those conditions where you do not prescribe any medications because it's not a long time, and you can simply treat them with CBT. Okay. This is also important to remember that PTSD, because they have like a lot of nightmares and flashbacks. So if you give them prazosin, which is an alpha 1 inhibitor, you can actually reduce the amount of nightmares. Yeah. Next, we have adjustment disorder. Now, adjustment disorder, right? It happens after like some kind of stress. So initially, you have some kind of stress, and then within 3 months after that stress, you start developing symptoms for adjustment disorder. And usually, these symptoms will only last for 6 months. And the kind of symptoms you might see are very varied. Could be emotional, could be behavioral, but this is important that they do not meet the criteria for any other psychiatric illness. That they do not have all six, sorry, that they do not have all the symptoms for MDD or all the symptoms for GAD. If they do present with all the symptoms for MDD, then you cannot think of adjustment disorder as the diagnosis. Instead, you will have to think about MDD as the diagnosis. Similarly for GAD. Treatment is still the same. You do CBT, first time doesn't work, you put them on antidepressants. And then yeah, this is all the timelines. Yeah. Okay. So yeah, those were all the conditions that I wanted to discuss today. So any questions about these from you?